Ladies and gentlemen, welcome to this lecture about lung scintigraphy. This is one of the most confusing topics for most trainees, so we'll see if we can make some headway into this. So we're going to talk about the scope of the problem, we'll talk about clinical evaluation, ventilation scintigraphy, perfusion scintigraphy, and various interpretation criteria, and as always in nuclear medicine, we'll mention pregnancy. So this is the data from a study that looked at the number of PEs diagnosed over time. And we can see that the number of cases seems to be rising dramatically. So PEs will wipe out our modern population way before COVID-19 will do that. But if we look at the mortality data for the PEs, it seems that the number of deaths is not going up. So we seem to be diagnosing a lot of PEs that are probably not clinically significant. So if we look at a relatively decent-sized data from an academic center, if we look at the emergency department patients, we see about 1,000 CT angiograms and only 65 of them were positive. That translates into about 6% of cases being positive. So if we read every single ED case as negative, we would really have 94% predictive value, which is really good for any test. And not surprisingly, that when we actually look at the number of positive patients based on the risk factors, we can see in patients with zero risk factors, which is about 500 patients, only 5% of cases were positive, and that is equivalent to 1%. And as the number of risk factors increases, at the point of having two risk factors, 20% of the cases is positive. At four risk factors, about half of the cases are positive. So the positivity seems to significantly correlate with the number of risk factors. Out of those risk factors, immobilization, hypercoagulable state, and prior PE or DVT seem to be the most predictive. Age and gender seems to play a significantly lower role, as well as malignancy, which is somewhat surprising. Now, by simple multivariate analysis, we can reduce those risk factors to this very simple formula, which all of you should be able to calculate on any patient. So when we're reading this in the future, I expect everybody to plug in the data into this formula so we can actually talk about the probability of pulmonary embolism. I'm just joking. All right, so this is a review paper that looked at various imaging modalities for diagnosis of PEs, even including electron beam CT, which is rather impressive. All of the tests seem to be excellent. However, this is likely related to an issue of gold standards. The most remarkable is that chest X-ray seems to have a 36% sensitivity and 92% specificity for diagnosis of PE, which is personally I think is complete nonsense. In the modern era, we don't really have a definitive trial that established what works. However, clearly there's a consensus of experts. So in 2007, Fleischner Society has published a white paper that said that CT is the gold standard. And this closely paralleled development of multi-slice technology. So in 2007, we had 64 slice scanners, which clearly proved to be superior to all of the other imaging modalities based on the opinions of experts, and I personally seem to agree with that. This is the American College of Radiology appropriateness criteria, and we can see that both chest X-ray and PE protocol CTA is rated 9, which is the highest. Now, I still don't understand why chest X-ray is there, but it refuses to die. If we look at the VQ scan, it is actually rated lower than the lower extremity Doppler, primarily because of absent radiation in an ultrasound looking for DVTs. But again, for our leading national organization, VQ scan is considered to be below chest X-ray and lower extremity Doppler test. This is what you need to know about scintigraphy from the American Board of Radiology, and we're going to discuss all of these topics in the subsequent lectures. So this is pretty straightforward stuff. All right, so this is the typical case We have a pregnant patient or not pregnant patient in a chest x-ray in the ED with chest pain, and the D-dimer is slightly elevated. And this is frequently because of IV access, damage to the endothelium. We have a little bit of a spill of D-dimer, so now normal chest x-ray and positive D-dimer, so CT or VQ. So these are the images from the actual CTA. This is a 64-slice CT scanner, and we see a few vague dots. Now I'm showing you these dots on axial images as well as in the coronal and sagittal reformats, and we can see that these are dots. Unfortunately, as radiologists, we tend to make stuff up, so this was actually interpreted as a positive test, and the referring clinician refused to believe it, and then ordered a VQ scan. And we can see that both ventilation and perfusion images are perfectly normal. There are no defects at all, and we read this as PE absent. And those dots that we saw in the CT were simply perfusion artifacts. And this is why we still continue to use VQ scans despite Fleischner Society saying that CT is the test of choice. In some patients, we cannot give IV contrast, or we cannot get a perfect study because of these flow artifacts related to injection, cardiac output, or other technical factors. So in this particular case, PE is absent. Okay, so lung scintigraphy is composed of pulmonary perfusion scintigraphy, as well as ventilation scintigraphy, which can be performed with aerosol or gas to assess ventilation and compare ventilation and perfusion to detect mismatched defects. Clinical indications for performing lung scintigraphy most often include suspected pulmonary embolism. However, we can also diagnose shunts, and we can also quantify differential pulmonary function for lung cancer surgery to see if the patient is a candidate for curative resection. Patient preparation. It's important to have anatomic chest imaging. CT is always preferred. However, chest x-ray is acceptable. In general, we prefer to have it within 24 hours, but be clinically reasonable. And if we have a normal VQ scan, who cares about the chest x-ray? And if the VQ scan looks really abnormal, then it becomes too important to have as contemporaneous imaging as possible. And again, CT is always better than chest x-ray. These are the most typical radiopharmaceuticals that we use. Technetium-99m has a half-life of 6 hours, has a photopeak of 140 keV. Xenon-133 has a much longer physical half-life of 5 days, which is why we're going to need the negative ventilation room, and we need the patient to breathe it out. The photopeak of xenon is way below the technetium, so we can easily do a xenon scan before technetium, but not the other way around. So once we have technetium on board, xenon cannot be used. Krypton is a fantastic choice. Unfortunately, not available in the United States. It has really short half-life. It has a photopeak of 190, so we would be able to do it along with technetium, but not in the United States. So this is the radiation dosimetry. Not surprisingly, lung gets the most radiation dose, with exception of DTPA, where the highest dose is bladder. So DTPA is not an acceptable choice for getting ventilation aerosol images in patient who is pregnant, because fetus will be close to the bladder and will receive a dose as well. Aerosol ventilation. This is really an excellent choice to assess pulmonary ventilation, because we're able to get multiple views. Disadvantages, and really there is only one disadvantage: it is a huge hassle to use it. And if the patient doesn't inhale correctly, it's possible to contaminate the entire room and knock it out of circulation. So this is why we have unfortunately not used DTPA, because most of our patients are non-compliant and would not be able to take an adequate breath. So DTPA is the agent of choice for performing aerosol ventilation, and the typical dose is about 1 millicurie that the patient actually inhales. Now, since we will be using technetium for both aerosol ventilation and subsequent perfusion, it's important that the ventilation dose is at least 3 to 4 times less than the subsequent perfusion dose. So this is an example of DTPA aerosol ventilation. So if we look at the images, we have the same views for both perfusion and ventilation images. Now in this particular case, we don't really need multiple views because it's easy to note that there are multiple mismatched ventilation perfusion defects, so this patient does have acute pulmonary emboli. Now in this case, it may be much more difficult to judge whether the patient does have ventilation and perfusion mismatched abnormalities, so I'll give everybody a few seconds to look at this case. And if you look at the anterior and posterior images, you will probably call this pulmonary embolism absent. However, if you start looking at the oblique, and particularly at the LPO images, you can see that there are mismatched ventilation perfusion abnormalities, so this patient does have pulmonary embolism. This is another example where we have multiple ventilation and perfusion views that are combined. So again, we'll give everybody a few seconds to look. And similar to the last case, if we look at the anterior and posterior, it is really difficult to detect mismatched defects, although on the posterior, on the left side, you can start to get an idea. If we look at the LPO images, that becomes obvious. So this patient does have mismatched defects, so pulmonary embolism is present. Gas ventilation scintigraphy can be obtained with Krypton and Xenon 133. And Krypton is a fantastic ventilation gas. However, it is not available in the United States, so for our purposes, this is a pointless slide. So what we are stuck with is Xenon ventilation scintigraphy. Now, unlike the aerosol ventilation, we're able to perform both single breath, equilibrium, and washout ventilation images. And we'll look at some cases that will illustrate advantages of that. Imaging room must have negative pressure. The negative pressure needs to be tested twice per year. Now, this is a testable question, so remember, negative pressure room needs to be formally tested twice a year. Optimally, the patient should be positioned upright in front of the scintillation camera. Now, in honest reality, with the cameras that we have, the patient is supine, but in theory, the patient should be upright. Posterior projection is the most important. If this is the only view that we can get, that's the view that we should get, although some institutions do use posterior oblique projections as the projections of choice. Now, typically we use single breath images for evaluation. However, we also obtain all of the others, and equilibrium is obtained by having the patient breathe in a closed delivery system for about 3 to 4 minutes, if the patient is able to tolerate it. And if you look at many of our clinical images, the patient can't tolerate anything, and Xenon ends up getting exhaled out in the room, which is not a problem because the room's a negative pressure, so it will get sucked in and cleared. So this is an example of Xenon for ventilation with subsequent perfusion imaging. And if you look at this for a few seconds, you can get to appreciate the advantages. And if we look at the Xenon washout images, we can see that there's really poor washout of Xenon, so the patient has severe obstructive airway disease, which actually accounts for why the patient was short of breath. It's not a PE, this is simply obstructive airway disease. This is another example. If we look at it, if we look at the perfusion images are fairly abnormal. Now, when we start comparing them with ventilation images on the initial breath, the ventilation and perfusion images probably match. However, as we look at the washout images, it gets a lot simpler. The patient has severe obstructive airway disease, which is what causes all of these perfusion defects. So this is not PE, this is COPD. Perfusion images are obtained with technetium-99m MAA. The biologic half-life of MAA is about couple of hours, 1.5 to 3 hours. The typical adult dose is about 4 millicuries. It's also important to note that the typical number of particles is usually about 200,000 to 700,000. If the patient has suspected right to left shunting, or in children, or in infants, or patients with severe pulmonary dysfunction, we can reduce the number of particles to about 100,000 without significant compromise of the image quality. So technetium MAA should be injected after the patient ventilates the lungs. So usually the patient is asked to have a cough, and while they are having several deep inhalations, the MAA is injected slowly during the 3 to 5 respiratory cycles. So if the tech is impatient and injects too fast, this will compromise the imaging. As we briefly mentioned before, the imaging should be performed in upright position because this is the most physiologic position of how we breathe. But again, not practical with the cameras that most people use, including us. So we perform this with the actual imaging is performed with the patient laying on the table. Ideally, perfusion should be performed with SPECT, so we have true 3D images. However, our techs essentially refuse to do this because SPECT takes too long, and most of our patients are not able to hold the breath, especially not able to lay still for that long. You don't need to hold the breath. Particularly because we try to get the patient's arms up, which is uncomfortable. So it takes far too long in a typical clinical scenario to get SPECT images of the lungs, despite the guidelines recommending that. So these are images from the European Society of Nuclear Medicine guidelines, and we see that the ventilation is normal. Perfusion shows a defect, which is mismatched on subtraction imaging, and this is what we'll look for. We include a map of the segments as they project on the anterior and posterior, as well as on the lateral images, so we can identify true segmental perfusion defects. Now, this is the fun part of the lecture, interpretation criteria. And unfortunately, the most accurate interpretation criteria is simply Gestalt assessment of an experienced reader. And this was a really nice study that looked at it, that showed an experienced readers can really accurately guess whether the patient has PE or not. I suppose this is like artificial intelligence. We know when PE is present, we know when PE is absent, and all of the interpretation criteria try to distill that knowledge into trying to teach trainees, and it really never worked all that perfectly. PIPED was the first major attempt from a while ago, and it stratified patients into high probability, intermediate probability, low probability, very low probability, and normal. So this is a lot of categories. None of us can rate it or apply it correctly, and the clinicians get really confused. Unfortunately, as every bad idea, this has stuck around, and Vision Radiology, who is our teleradiology provider, continues to use these categories. So when I see this intermediate probability and very low probability, I start tearing my hair out, which accounts for my hair absence. Despite my many requests to abandon this, people continue to use this. So bad ideas stick around. This is data on utility of criteria and diagnosis, and really based on this data we can see that it's the high probability that tends to be useful, and normal or near normal that tends to be somewhat useful. However, even those reads seem to be affected by preclinical probability. So if we look at the high probability scan but look at the low clinical probability, only half of the patients have the PEs. In the normal and near normal categories, clinical probability doesn't seem to make much of a difference. So these criteria seem to be quite flawed. So this has led to revised PIPED criteria. that has reduced it to high probability with 2 or more mismatched segments, intermediate probability, which is a terrible category but seems to encompass most of the patients, and really has the probability of PE between 20 to 80%, which is craziness, and then low probability, which is less than 20%, but still that seems to be relatively high as well as normal. So revised pipette slightly better, but not that much better than the actual pipette. So again, this continues to cause problems. Really, all we did is removed very low category and slightly simplified the language of the guidelines. As the technology evolved, it led us to the Pipette 2 trial, which aimed to compare VQ scan and CTA for diagnosis of PE. And this trial is often cited, or used to be cited, to say why CT was so bad. Now, I actually remember how the Pipette 2 trial was conducted. Most of the scanners in the trial were actually 4 slice or less. Only some of these studies were done on the 16 slice, so forget the modern interpretation with 64 slice. Furthermore, most of those cases were read before the existence of modern PACS, so images were read on the printed sheets of film that you can't window where the pulmonary arteries were tiny. So you really couldn't find a PE on them, so the data that produced on that, based on that trial, I think was largely nonsensical. So comparison of Pipette 1 and Pipette 2 was extensively published, but frankly I think it was mostly useless. One key and relatively logical data point that came out, the more mismatched segments we have, the more likely it was that the patient actually had PEs. So based on that trial, with 1 segment, only half of the patients had PEs, but with 2 segments, 71, and with 4 moderate segments, it was 100%. So the more segments, the more likely that the PE was present. So eventually this has led us to more modern interpretation criteria, and particularly modified Pipette 2, which has significantly improved, as well as the perfusion-only interpretation criteria that used 3 discrete categories, which is what we use now. So PE present, and in modified Pipette 2, this was 2 or more segments. In perfusion only, however, it was only 1 or more wedge-shaped perfusion defects. PE absent, which was normal perfusion or something close to it, as well as non-diagnostic, which was all other findings. And this is much easier for clinicians to understand. PE present, PE absent, or the exam is non-diagnostic. Key difference in modified Pipette 2, 2 defects. In perfusion only criteria, single defect is sufficient. And the data that looked at those interpretation criteria showed that they were actually pretty decent. In modified Pipette 2, PE absent sensitivity was 85%, PE present specificity was 93%, and only 21% of the exams was non-diagnostic. Now, the perfusion-only criteria actually performed quite a bit better with 0 non-diagnostic exams, which is probably too optimistic, but in my personal experience is actually relatively realistic to approach in clinical practice. This is the comparison of all of the various criteria. Again, in Pipette we had 2 defects, which were continued in modified Pipette 2, and then perfusion only guidelines reduced it to 1 or more defects. And again, all of these categories of very low, borderline low were collapsed, and intermediate scans became non-diagnostic. This finally leads us to the criteria that we actually use these days in our clinical practice, which is European Association of Nuclear Medicine VQ guidelines, which are probably the most practical. So this is called normal if the perfusion pattern is normal, or the mismatches don't have a lobar segmental or subsegmental pattern, and PE reported as present if there is a ventilation perfusion mismatch of at least 1 segment or 2 subsegments that conform to pulmonary vascular anatomy, and non-diagnostic is non-diagnostic interpretation rendered in all other cases. So let's look at some practical examples and let's see if you can apply these European Society guidelines to diagnose PEs as present, absent, or non-diagnostic. So I'm going to ask everybody to look for a few seconds at each image, and then you can come up with your own conclusion. So this is PE absent. If we look at the perfusion images, they're perfectly normal. Frankly, there's no reason to even look at the ventilation images except to diagnose obstructive disease, and whether I have a chest x-ray or not in this particular case is irrelevant because perfusion is normal. So PE is absent. All right, how about this case? We'll give a few seconds for everybody to look at the perfusion images carefully. Remember, you're looking at one segmental or two subsegmental wedge-shaped perfusion defects, which are absent in this particular case, and this can be interpreted as PE absent. All right, let's look at this case. Well, this is slightly more complicated, so I'm going to give everybody a few seconds to look at this and decide what would you want to say about this. So absent, present, or non-diagnostic. This is quite a bit more challenging, so actually you really have to compare. So this is PE absent. If you carefully look, all of the perfusion defects are matched on the ventilation images. The patient also has obstructive airway disease, which is probably accounts for that heterogeneous perfusion and ventilation. This is not pulmonary embolism, this is obstructive airway disease. Okay, now let's look at this case. This is a little bit more confusing, but ladies and gentlemen, you're really smart, so you should have no trouble figuring this out. I'll give a few seconds for everybody to look and decide what you would like to say. All right, and this is PE absent. What we're actually seeing is we're seeing perfusion and ventilation of only single lung. Left lung has been surgically removed, so we really should not have either perfusion or ventilation, and in the right lung itself there are no perfusion defects, so pulmonary embolism is absent. A little tricky without the chest x-ray, but you guys are really smart. Okay, let's look at this case. We'll give everybody a few seconds to look at the images and come up with your own conclusions. And I'm sure all of you have said pulmonary embolism is present. We see multiple mismatched ventilation perfusion defects, and a DVT ultrasound in this patient showed thrombus in the left popliteal vein, so we have both DVT and PE present. Okay, another case. We'll give everybody a few seconds to look at this and come up with your own conclusions. So this should be relatively straightforward, and I'm sure all of you conclusively said that PE was present, and if we look in this patient, DVT scan was also positive, so this patient had both DVT and PE. Okay, slightly more challenging case for everybody. Please take a look. We'll give everybody a few seconds. And I'm sure all of you quite confidently diagnosed this case as PE present because we see multiple mismatched ventilation perfusion defects, which are especially evident in the left lung when you look in the posterior ventilation and perfusion images. And this patient had occlusive thrombus in the left popliteal vein, which probably accounted for positivity. Again, all of you sensing a pattern that the patients that have PEs, we're also seeing positive DVT exams. Although if you look at the actual literature, out of the patients with proven PE, only in half of them we can identify an underlying DVT that accounts for that embolism. So we don't know where the rest of them come from, whether they form in situ or they form in some sort of a pelvic veins, or they just all form and break away and go to the lungs. Okay, now look at this case. This is even more challenging, but you guys are really, really, really smart. Okay, Now this case is again PE is present, and again we're seeing a positive DVT scan. Now, remarkable enough, this is actually an upper extremity DVT that we found in this particular patient. But when we look on the right anterior images, we can see that in the apex there's a clearly mismatched defect between the perfusion images and the initial breath ventilation images. So in this particular patient does have PE and DVT, as you can see. Okay, how about this case? See, they get more and more challenging, but you guys are really, really smart. Okay, a few seconds to look. And I'm sure all of you have concluded correctly that this patient has PE. We can see multiple segmental mismatched ventilation perfusion defects. So this patient has PE. Unfortunately, I don't have a DVT scan for this patient. Okay, how about this case? This will require some problem solving. I'll give you a few seconds to look at all of the images and come up with your own conclusions. Now, I would like to specifically point out that on the lateral images, the arms are down, and this causing this attenuation artifact, which underscores the challenges of keeping the arms up for this type of exam. Patients really hate raising the arms up because the shoulder is not designed to be in that position, so it tends to be quite painful, especially for elderly patients or patients with underlying rotator cuff disease. Okay, so in this case, PE is absent, and the cause of the perfusion and ventilation defects is pulmonary effusion, which is well seen in the chest x-ray. Now, the matched defect at the right lung base is particularly well evident on the posterior images. If we look at both ventilation and perfusion, we can see that the right lung does not go down nearly as far as the left, and that attenuation is caused by the fluid that's accumulating at the lung bases. Okay, pregnancy. So these are some of the guidelines that were published in the past that recommend using VQ scan in pregnancy if the chest x-ray was normal, and CT if the chest x-ray was abnormal. These are the fetal doses. You can see that in chest x-ray the fetal dose is negligible. However, when we compare the VQ and the CTA, the fetal dose is actually higher with the VQ, although the maternal breast dose is less, which is kind of interesting that the guidelines recommend the test with a higher fetal dose. So typically in the modern environment, we actually use CT as the test of choice. Particularly the better CT equipment, the better off we are. Now, the note of caution is that both VQ scans and CT scans get somewhat more difficult in pregnancy. The published data suggests that that problem is for both, but in my experience, VQ scans actually do not deteriorate. The reason the CT scans deteriorate is that pregnant women have higher cardiac outputs, and the moment the cardiac output goes up, it gets a lot more difficult to get a diagnostic bolus. So what is the answer? Well, the answer is faster injection rates and faster CT scans. So both of those factors help us quite a bit. So in a modern Siemens dual source scanner, we can get the chest scan in under a second without having the patients to hold the breath. So that significantly improves the quality of our PE studies. But nonetheless, in pregnant patients with high cardiac output, if the injection rate was not fast enough, we will see significant deterioration of CTAs. But all of the VQ scans in this patient seem to remain diagnostic, at least in my experience, although the published data suggests the deterioration's equal. Okay, breastfeeding. If we did do a VQ scan on a patient who is breastfeeding, they should interrupt breastfeeding for about 12 hours, and that's because of MAA. So if we just use xenon or krypton, we don't need to interrupt, but no one would use the gas without using a perfusion images. So you should remember that patient who's breastfeeding should stop breastfeeding for 12 hours. Sources of error, it's really easy to screw up a VQ scan. It's particularly easy to screw up ventilation images if the patient doesn't breathe. With perfusion, it's a relatively robust exam. If the IV doesn't work, it doesn't work. However, with a VQ scan, we can use a much smaller gauge IVs. It doesn't matter whether it's in the hand or antecubital fossa. Anything that has a blood return can be injected for the VQ scan. Okay, take a look at this case. See if you can figure out what went wrong. And I'll give you a few seconds to look at this. This is a fun case. Pretty difficult, eh? Well, I'm sure you have noticed a couple of things, that both the perfusion images and ventilation images, and this was DTPA, of course, because all of the views are matched, look absolutely identical, which should never happen. There's also some central airway clumping, which is not great, but very common if the patient is not taking a deep breath. But the images should not look the same. Now, take a careful look at the arm on the left side, and the arm is really, really bright. So this suggests that there is either extravasation or clot in the veins that prevents the inflow of MAA. So all we're really looking for at this case is counts from the DTPA aerosol. The MAA that we injected never got to the lungs due to extravasation or DVT. How about this case? I'll give you a few seconds. So this patient had hypoxia. And when we look at the ventilation images and perfusion images, the lungs look identical, but we're seeing a ton of activity outside the lung on the perfusion images. So this is a patient with right to left shunt. The most sensitive evaluation is, of course, just looking at the brain, but in this particular patient, there is massive shunting, and we can see activity all over abdomen from right to left shunt, which is the actual cause of hypoxia and not pulmonary embolism. So VQ scan is actually a really neat test. It used to be a lot more common. Nowadays, cardiologists do echoes with bubbles, which seem to work really, really well. I'm aware of at least a single case where on the VQ scan we didn't see anything, but cardiologists were able to notice bubbles flying across. And were able to diagnose it, and that was a true positive case. I think these days, in majority of patients, echo with bubbles is more than sufficient for detection of right to left shunt. Preoperative evaluation is quite useful. It really depends on the surgeon and the type of patient. Frankly, I think if the patient is a borderline candidate, stereotactic radiation or ablation is a much better choice. However, surgery remains the superior to other modalities if the patient can undergo lobectomy. However, what frequently happens is patients who are borderline, they tend to be oxygen independent before and become oxygen dependent after. So quite challenging to manage afterwards, and it's important that the patient understands that. So in any borderline cases, we really like to perform preoperative testing just to see how much of a deterioration there will be afterwards. Post-transplant, again, can be quite helpful, but in the modern day, not done all that often. All right, so in summary, let's talk a little bit about VQ Anonymous. So CT is much better than VQ, but if the patient is really obese or pregnant, VQ can be better because of cardiac output issues. If the chest x-ray is normal, if the chest x-ray is abnormal, don't use VQ scan. Step 2, you must commit to never render low probability or intermediate probability reads because they are frankly useless. So remember to use PE present, absent. Now, step 3, and I think this is the most important one, look at the images for 3 seconds, which is my personal attention span. If PE is present or absent, that should be evident. Now, if you notice yourself still looking at the images after 30 seconds, the test is non-diagnostic. So, also remember VQ is excellent for right to left shunts and detection of airway obstruction disease. Okay, well, thank you very much. And this is based on my personally published guidelines of why you should have gone into dermatology instead of nuclear medicine. Thank you for your attention.